Good morning. I hope y'all had as much fun as I did last night. Actually, I saw a few of you outside. You had more fun than me, I could tell. So thank you especially to those people for actually making the effort to wake up after that. We're going to be visiting today about actually a conversation I had yesterday. I was wanting to meet one of the speakers, and I introduced myself, and he goes, "You're the Airway guy." And I was like, I'd kind of rather be known as the restorative guy or the prosthodontist guy, but I get it, I'm the Airway guy. In fact, one of my mentors said, won't it be cool when we don't have to say airway or airway prosthodontics anymore, we just say dentistry? That's kind of where we're headed with all this, but I get it. And he said, I'm really interested in your lecture because we don't do much airway where I'm from. Well, that implies that airway is a thing, an item, an appliance, and it's actually a way of thinking through treatment planning. So we're going to visit about my vision of what airway really is and how the world of sleep dentistry has kind of warped that vision and made it more difficult for people to accept. You see, it was only a couple of years ago I was out here for the first time. 2016 at the summit is when we introduced this to Spear, and I said, there's a revolution coming and Spear should lead the way. We ought to change EFSB to say that it's AEFSB, and I made the analogy, it's just like changing the spelling between what we spell here and how they spell in England. Just add an A. It's that easy. It wasn't exactly that easy, but if you actually look at the Spear curricula today, which is 2 years after I joined, you're going to be hard-pressed to find a course that we do where we're not mentioning airway in it. It has gone into every single course we do, and in fact, from a treatment planning perspective, it's so important that we've actually changed how we introduce the airway workshop. Today, starting in 2020, you have to actually go through FGTP and occlusion before you get to the airway workshop because it's about treatment planning. It's not about making a tool or an appliance. It's a way of thinking, and you have to have a background in how to treatment plan before the airway really can be impactful in your particular practice. And so I do get this question quite a bit. I went to the lecture, how do I implement it? What do I do? What's the next step? And I think what's messed us up is you think of it as being sleep. You think of it as being, I'm going to make an appliance, and that's the key. How do I make something for the patient? That's not the key. The key is you're going to just do dentistry. Now I'm going to show you, for those of y'all that have come to my workshops, come to the seminars, looked at the stuff online, I'm going to show you a bunch of pictures now. And as you look at patients that are walking into your practice daily, and you meet them and walk down the hall next to them and give them that little elevator glance that we give all our patients, just looking from the side, and now you start looking at them smile at you and you have them bite down for you, you start seeing things differently. You start evaluating the maxillary arch and the dimension of the arch. You look at the occlusal patterns that they have. You look at damage on the teeth, how they're wearing the teeth from erosion, from bruxism. You'll then start evaluating the nose, which you've never done before. And you've looked for three things: septums, turbinates, and the ability to breathe without the nose collapsing. We call it nasal valve stenosis. You look at the tongue, and instead of just feeling around on the tongue and looking for areas of cancer on the tongue, you're actually taking note of the tongue. You're looking at tori and evaluating the space that they take up. And finally, you're ending up in the oral pharynx, and you're looking at the structures differently. For those of y'all that have gone through the courses or really invested some time in this, there's not a single one of you that sat there and didn't look at those cases and go, airway, 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 airway. In fact, it's like Waldo. Find the one that isn't airway, because they all are in some way, shape, or form. You see, that's what airway is. That's how it impacts your practice. It impacts you because you can't see the world the same. It is a treatment planning change. Now, I feel like I'm in a good position to actually tell you and talk to you about treatment planning changes because I kind of lived through all of them. This is me moving into the clinic in 1986 in dental school. And I have lived through every one of these treatment planning concepts. The first one I learned is we got to work off the mandible. The mandible is the most important part. It was the spherical theory of occlusion, Monson's sphere, Bonwill's triangle. I learned about Spee and Wilson's curves. We would then take a Broderick flag and outline exactly the arc that I was going to develop the lower on and how I was going to wax and what teeth I was going to adjust. And then I would finally pay attention to the maxilla, but honestly, it was the lingual surfaces of the upper anterior teeth that were the most important to me. In 1990, I did my first pantographic tracing, so I was working at a higher level of the mandible and trying to figure out occlusion at a somewhat higher level. But I have to be honest with you, the moment I mounted the maxillary cast with a face bow, be it off of a terminal hinge axis or just off of an arbitrary position, the moment the maxillary cast was on the articulator, it was the last time I thought about what I was going to do with the maxilla. Everything else was about how do I seat the condyles, how do I get bilateral simultaneity of contact, and how do I disclude them through the teeth without running into other teeth. It was totally about the mandible. The maxilla didn't play a role at all. It was a very mechanical way of thinking about the mouth, when in fact the problem was biologic all along. You see, the problem was the maxilla was too small or in the wrong location, and I had to warp my thinking in order to make it work. So why would all these smart people that came up with these occlusal ideas, why would they do that? Why would they be so focused on the mandible? And the answer, I think, is because they didn't have an orthodontist that could move the maxilla around. You see, at the time occlusal concepts came out, they couldn't say move the teeth into another location. They said, at most for an orthodontist, upright a molar so I can do a bridge. Now, that's a foreign way of thinking for many of you, but that's our world. That's where it came from. It wasn't until the 1980s, in fact, probably 1985 in particular, that Frank introduced the idea of looking at the upper arch first. And honestly, I haven't talked to him about this, but I would suggest or believe that it's probably his vision came because of the interdisciplinary nature of what he did, working with Dave Matthews, who you'll see him with tomorrow. But also more important in the group than anyone else was Vince Kokich Sr. For the first time, a world-class orthodontist became part of an interdisciplinary team. And so now Frank could actually say, we need to start working off of aesthetics first. It's like setting a denture. Put the teeth where they're supposed to be, and he had an orthodontist that could do it for him. Then we can focus on the lower arch. Lower arch is important. Occlusion is important, but it's got to come secondary to where the maxillary teeth are. Now, Frank, as you know, named it facially generated treatment planning. The idea was, how do you know where the teeth belong unless you actually evaluate where they are in the face? Our concepts from that point forward here at Spear have always been a 2D concept. You visualize where you want them to be. At the beginning, we would actually draw them on paper. Today, we have templates where we overlay like you just saw. That's a two-dimensional view of a three-dimensional world. And so aesthetics, function, structure, biology is a 2D way of thinking. Today, we're thinking of FGTP in 3D. So let me explain. What has Frank always said about setting up a rehabilitation? He said it's just like doing a denture. You begin by setting the central incisors and get the incisal edge position correct. That's how you do a rehabilitation. Yes? Now, for those of y'all that do dentures, you remember, it was funny. There was like a whole group of people when I said do denture, y'all went, ooh. And there was one that had a twitch in her eye, like it was the PTSD from a denture deal. All right, so think back to a denture that worked well and how you did it. Did you go in to the laboratory, get the case pan with the wax rim, grab some teeth, walk into the room, warm the wax, and cram the tooth in? Did you do that? And the answer is no. Not a soul. No one does it that way. What do? You get the wax rim out, you put it in the mouth, and you evaluate it for what? Lip support and transverse dimension, right? Not one of you would accept a wax rim that was off. So you would add wax, subtract wax, but eventually you go, the lip support is fine, the transverse dimension is fine, now I will begin setting the teeth. AP and transverse, that's the airway. The problem that we've had for years, though, is we've been willing in restorative dentistry and orthodontics to work to a lousy wax rim. Imagine if we went in on our dentures and said, you know, the wax rim is undersupported and it's a little tight on the left-hand side. I guess I can use smaller teeth and maybe kind of push it out a little bit. That's what we've been doing. Today, you don't have to do that anymore. You can make the wax rim any position you want it to be. Orthodontists can change this. This is my son, Jake. A lot of y'all know about him. Jake's now 15. He's 6'4". If he gets a pitching contract, he's my favorite of all my kids. Jake still can't breathe very well, and I need him to breathe. And so we said, you know, your ortho's looking good, but you still got a problem. You're still deficient in mid-facially. I want you pulled out a little further. We protracted him when he was littler, but it didn't work at all. And so now we're protracting him again. We put a Marpy in his palate. We expanded his palate. We've broken the maxilla free. And now we have bollard plates on the lower anteriors where he actually runs constant pull elastics too. So I'm putting the maxilla where I want it. I'm not accepting that it's where it's going to be and just leaving it alone anymore. So you're very aggressive the moment you mount the maxillary cast in looking and saying, this is where I really want it. By the way, we added composite. He wasn't so thrilled about the whole idea of the diastema. So Airway dictates that though. Airway says the wax rim is wrong, let's make it better. So if the maxillary wax rim is the key to this, let's figure out what controls the growth and development of the maxilla and what might get in the way and what impact it may have. Because I'm going to suggest to you the maxilla is the key. Maxilla is the key to everything. If we get it right, the patient looks good, functions well, and is extremely healthy. Now, this has been written about by orthodontists like Ricketts since the 1950s. Ricketts said that it appears that nasal breathing is what grows the maxilla. It creates a normal maxilla, which then creates normal occlusion. And the most important line is the last line. The well-being of the whole child depends on this. You can make people healthy now by just doing dentistry. Today we know that if they're breathing through their mouth, which would be abnormal, that is not healthy. That is the precursor to apnea. That in fact, we're going to see that way earlier than physicians can see any medical change at all, so we can intervene earlier. When we don't have normal breathing, they're going to start breaking down, and they're going to break down neurologically, which means that people that were able to take care of their airway earlier can't do it anymore. Because night after night, they had to fight the battle, and they lost the battle over time. And the last thing that Guilleminault tells us is the key to all of our treatment planning and our final treatment is you have to be able to get your patient to breathe through the nose, which means you've got to grow the maxilla out to the position where they can. So if the maxillas are too small, the next question would be, why are they too small? And I would suggest to you that they could be born with too small a maxilla. Children that are premature will always have an underdeveloped maxilla, and in fact, the data is suggestive of the fact that 100% of the time these children will have sleep-disturbed breathing issues. It's just a matter of when and how bad the problem is, and it's all craniofacial. The other reasons are the things that we require to grow the maxilla aren't working correctly. Meaning, if you open your mouth and take the tongue off the roof of your mouth, you're not driving growth and development in a downward forward direction. Or if you can't breathe through your nose for some reason, big adenoids would be an example, you open your mouth and you don't grow the maxilla correctly, or if the tongue is tied. Those would be some explanations. Because you remember, the maxilla grows from intramembranous growth. It's force that makes it go where it's supposed to be. It's not endochondral where there's a preset pattern for it. So mouth breathing can cause the maxilla to be too small. And remember, the floor of the nose is the roof of the mouth. So when you and I start seeing people with narrow maxillas, you have to now assume their airway volume is too small and the resistance to breathing is too high and they are not healthy. That's not even considering they're not as attractive of a smile and it doesn't bite as well. They're not healthy because the maxilla won't grow in the correct direction. So looking at young fit children, young fit females, and old fat men, you need to look at the maxilla. And when they smile and you see excess buccal corridor, the first thought shouldn't be aesthetic anymore. The first thought is, you can't breathe. And we need to do something to make it better. Now, when the maxilla constricts in all those dimensions, AP and transverse, what happens to the soft palate? And the answer is, the soft palate will drape down the throat more. So when you do an examination on a patient and you see that they have a Mallampati 3, Mallampati 4, essentially the soft palate is impinging on the airway, instead of thinking, oh my gosh, genetically you were gifted a long soft palate, you need to start saying the maxilla is totally in the wrong place. It needs to be wider and it needs to be more forward, because if it's in the right place, the tissue will rise into its normal location as well. Why is that important? Because the soft palate's the number one point of obstruction. If you're going to have an obstructed airway, it more than likely comes from the soft palate. And the soft palate obstruction, more than likely, is because the maxilla is in the wrong location. The next area would be the opposite. I said mouth breathing causes problem. Think about it a different way, which is lack of nasal breathing. I didn't breathe through my nose. You see, when you open your mouth to breathe, the tongue drops down. That keeps from driving the development of the arch. But if you don't breathe through your nose, you actually don't grow the maxilla internally as well. Nasal airflow and nasal usage grows the maxilla. So the inability to breathe through your nose creates transverse and sagittal dimensional changes in the maxilla. What about the tongue? I already said when you open your mouth, tongue drops down. Tongue is really important. Kids that are nasal breathers will have the tongue in the roof of the mouth while they're breathing, while they're swallowing correctly, so that the arch can be developed. Kids that are breathing through their mouths, the tongue drops down. How much and what impact? Well, John Mew gave us a graphic description of it years ago. He said the more the tongue drops, the more the maxilla constricts. This is happening to look at it in a transverse dimension, but it also is an AP component to it as well. The two that you see all the time are when you get scalloping at the edges of the tongue. That means they're clamping against it on their posterior teeth. Rarely does the tongue go forward. It likes to go laterally. When it goes laterally like that and you hold on the tongue, the anterior teeth can over-erupt. That's your deep bite anteriorly with a stepped up occlusal plane in the posterior. It's about the tongue. It's about what the tongue did in order to actually breathe. Number 5 is when the tongue drops down to breathe around enlarged tonsils. And we know that's what patients with huge tonsils have to do. When the tongue drops that much, what you do is get bilateral crossbite and your occlusion anteriorly is end on. So when you see a person bite down and their front teeth hit end on, you go, tell me about your growing up. How many times did you have sore throats? Because that's the answer. That's what's coming. Next is they want to raise the tongue, but they simply can't. And we now know there are actually 4 different types of tongue ties that exist. The first 2 classes are class 1 and class 2. Those are anterior tongue ties where the fibers run to the tip of the tongue. Types 3 and 4, I did not know, or class 3s and 4, I didn't know about for years. Many, many years, until just recently, actually. They are posterior tongue ties. The fibers, instead of traversing to the tip of the tongue, go deep into the body of the tongue. In a class 4 tongue tie, you really don't even see it. You just see the effect of it. Now, how do we go about finding them? For me, I want to do something quick. So the first thing that I would tell you is on all our exams, we're doing cancer screenings, right? And we palpate the floor of the mouth, yes? When your finger's down there, you can run your finger past the frenum. Now, everyone's got a frenum, but normal frenums are elastic. They just move. Frenums that are functionally tongue-tied, they're collagenous. They're a totally different type of tissue, and you will feel the taut area. The other thing then I would do is have them open wide, which I've done for my functional examination already. Then I say, while you're open wide, put the tip of your tongue up right behind your central incisors. Now, they're going to have to close to do this. they ought to be able to stay open basically half the distance or more. The other thing people will do is cheat. Sometimes as they drag the tongue up, they bring the floor of the mouth with it, and that's cheating. You can't do that. So you have to watch that people don't do that as well. So what does that mean if they're tongue-tied to growth and development of the maxilla, because that's our topic for today? Audrey Yoon tells us the maxilla doesn't grow as well. Why? Because the tongue didn't get to the roof of the mouth. And it just depends on how tied they are as to how constricted it is. What else does she tell us? If they have a tongue tie, the soft palate drapes down the throat, and that would make sense as well, correct? The maxilla doesn't grow, the soft palate's going to drape. Guy Monod picked up from there and said, you know what? If they have a narrower maxilla and a soft palate that drapes down the throat, they're going to be more prone to having these airway issues, and sure enough, he showed that. Final part, new study that just came out that said, what happens if you do the frenectomy and you work with a myofunctional therapist to retrain the tongue? And the answer seems to be good things happen, because the tongue can leave the airway and go into the mouth if we obviously provide it room. It said the majority of the patients were very satisfied. The majority of patients that were clenching and grinding stopped, probably because they can breathe through their nose. The sleep quality went up, probably because they can breathe through their nose. And the final part is they can breathe through their nose. That's a huge advantage. Why? Why is it better? Because number 2 point of obstruction is the base of tongue. And it gets the tongue out of the floor of the mouth and out of the airway and to a point where you can actually breathe better. All right. The next thing that I keep hearing is, this is a huge topic, where do I begin? So let me see if I can answer that with the last couple of minutes that we have here. Yes, it is a huge topic. What have we done here at Spear to make it more manageable for you? And that's the utilization of the online forum. So there are now 19 courses that I've done over the last couple of years. There are 5 pathways. There will soon be 7 pathways. There are over 12 hours of content that I did. There's other content on there, but I did it. So you're going to hear the same message for 12 straight hours. It's a Netflix weekend, right? The Seattle Protocol videos, all 6 steps are coming out this next Monday. So in a couple of days, you'll have all those videos. And finally, for those that are in study clubs, you've been begging for the idea of getting study club modules that had Airway as its core, and that's coming in 2020. We made a very conscious decision that we had to have a foundation of information on the online forum before we did that. Now we feel comfortable with that amount of information, and so those will be coming. My favorite video, by the way, selfishly, is the one we did on this chairside demonstration. Every step in the operatory, every communication that is done with the patient, and all the laboratory steps have been videoed for you. Why selfishly? Because Megan, my assistant that does this, keeps threatening me that she's going to get pregnant. I keep spiking her husband's water in hopes that it doesn't happen, but it's probably going to happen, which means I'm going to have to do what? I'm going to have to train someone else. And when I train someone else, now I don't have to train someone else. I just tell them to go watch the video. Tomorrow we're doing step 3. Please watch that video tonight before you get to the office. The last part is the Seattle Protocol, and it's something that Greg and I came up with when I worked up there for a couple of years with him. And the idea at its core is we'd love to prevent the problem from ever occurring, but we realize we're going to miss some people. And therefore, we need to control their disease. We need to make them something. Unfortunately, in the world of sleep dentistry, it's about making them a sleep appliance. And I have some problems with that. I don't think that's for everyone. I think they need the appliance for them. But I also believe that we ought to provide resolution strategies for every single patient. So when we walk through the Seattle Protocol, the last thing is, here's your piece of plastic that's going to control the problem. How can I take that back from you? Because the piece of plastic only works when you're wearing the piece of plastic, which means all day long you're having more difficulty breathing. You're not healthy sitting here right now because we didn't fix you. We just controlled you. The other cool thing is it provides a proof of concept. In other words, how are you feeling? I feel great. Would you like to feel like that all the time? Yes, I would. Well, here's how we do that. Here's how we can make you into the appliance. So they've seen the advantage ahead of time. Now, I have to tell you, I've been doing dentistry 31 years. Gregan's been doing it 26 years. And the other day in our FGTP workshop, we were talking about it. And I think I had about 10, maybe 12 people at the most go through orthodontic surgery. And he had 5. So we had between us, let's call it 15 patients that had, in our careers, gone through orthodontic surgery. In my practice right now, I have 12 ready to go. And we're doing MARPs and SARPs. We're doing tremendous amount of surgical intervention to get the maxilla right because people want to be healthy. That's the regenerative patient that Frank has talked to you about for years. You want to get a patient that fits at this highest level? What has he told us? He said, I do the dentistry because I want what is best for me. Now, I used to think of that as crowns. It's not. I want to make myself healthy. If you need to do crowns and such along the way, that's awesome. I would love to have a prettier smile. But it's not all about that. It's about, I want to be healthy. Lady the other day said, I'm 58 years old, I've been married for 35 years, I don't care how I look. And I said, that's great, because I don't care how you look either. I said, all I care about is that you're healthy at the end of doing this. And oh, by the way, you're going to look a lot better. I'm sorry. You want this kind of patient in your practice. You want Christy. Christy's the type of patient that we want. Christy is actually a dentist. Christy for years knew that she hated her smile, hated her profile. She knew orthodontic surgery would be appropriate. She also knew that she had a joint issue. 2004, that was her bite. When I met her in 2016, that was her bite. I looked at her because she came up to me at a lecture and she said, you're talking about me. And I said, okay, you got a joint problem. Probably have an airway problem too, but you got a joint problem, and I'm not taking care of you until you get it checked out. So she went back, and in fact, her joint problem has remained stable since 2004. There have been no changes at this point in time. So what made the bite change? And I would suggest to you, the effort to breathe would made the bite change. The tori, by the way, I never had an answer for, and a recent study said, you know what? Tori actually affect the severity of the apnea, especially if it is a position-dependent type of apnea. So that's going to be part of the treatment plan to get rid of them. What we found is she has chronic sleep problems. She can't sleep over her back. She gasps. In her sleep study, she had no REM sleep at all, and she had significant levels of apnea. Her airway's too small. She needed it addressed. We walked her through the protocol and came up with an appliance. But it's silly to wear an appliance, right? Because all day long she had the problem as well. So we said, you know, you really just need to be fixed. So I helped direct a bunch of her treating dentists over in Atlanta walk through this to get her ready for doing orthodontic surgery. Mike Gunson did the surgery back last summer. That's her bite 3 weeks post-op. That's 2 months post-op. That's 6 months post-op, and she just completed the care just the other day. Now, the neatest part about it is not the aesthetics or the fact that the airway is so big. The neatest part for me is the fact that she recognized it, that she loves it. She said, on June 17th, I underwent a Lefort 1 and a BSSO to correct my occlusion and airway issues. Now, just a few months later, I'm amazed at how I can sleep on my back all night long, no gasping or heart racing. I have more energy and don't tire as easily. The surgery was not an easy one, and the recovery as I continue through orthodontically straightening my teeth and waiting for the feeling to return to my chin is certainly going to be a journey over the next year, but I do it all again, no question. Breathing trumps everything. When I was diagnosed with sleep apnea, I was frustrated to have to deal with this problem during a busy time in my life, but God has used my journey to transform my practice to make me a better dentist. I became a dentist because of my desire to help people, and now I'm helping families by looking at tonsils in children, as well as jaw development, narrow arches, continued thumb sucking, bedwetting, allergic sinus, hyperactivity, snoring, all signs of sleep disorder breathing. And I'm helping tired adults and those with worn and broken teeth become not only dentally healthy, but healthier overall by recognizing potential breathing issues and helping them get treatment. And I know that God is using me to encourage you, my colleagues, to look for the signs and symptoms of sleep disorder breathing as we see in our patients every day that could be decreasing the quality of life and may lead to health issues and dementia. I hope your practices become transformed too. Thank y'all.